Recording. All right, welcome, friends. I'm Kelly Schmidt, and I am so excited that you're here. To kick off, we have started to comment in the chat where we're located, and overall, I feel like I've been waiting for you to connect with me. So this conversation, this community call really was inspired from an Instagram post. And it was an Instagram post that, I think I have a lot of convictions with type 1 diabetes. I think there are a lot of guidances that we're giving. And I also think type 1 is really tough. It's the biggest biofeedback loop that anyone could dance with on a daily basis. And I think there is so much more to explore. And I hope deep conversations like today can help that. So I just wanted to know where everyone was from. We got New York. And as you join, feel free to comment where you are. We have 17 people. Again, I'm expecting closer to 40. It's okay if people don't make it as I have the recording going, so be careful what you say. Philly, we have a few people in Philly. My husband's there right now. All right, I'm going to go through this next slide. This will not be all slides because it's really about the connection. That's what I care about today is feeling seen, heard, and connecting. And there's a really fun activity I'm going to have us do. Like, who knew there was an icebreaker to do a Zoom? And there is. So this is what we call Chatterfall, and this is how we're going to break the ice to kick off the hour. And we're going to be a solid hour. We're going to be efficient, and I want to make the most of every single minute. So in Chatterfall, in the chat, what you're going to do is you're going to type one word right now on how you that describes your T1D. It can be how it's treating you. It can be a word that describes your T1D management. It can be anything, but everyone don't send enter yet, but everyone type one word or two um, in the chat. And in about 5 or seconds so, I will say go and we'll all do it at once. So don't do it yet. We had Marlena lead the pack. I like it. Winning, winning. All right. And three and two, we're all going to hit enter. And one, overwhelming, roller coaster, inconsistent, confident, continual, tiring. Okay. Easy going. There's my word, perimenopause. That's my word for T1D. Um, Rachel's on here. Awesome. Resilient. I'll be handing the microphone over to Rachel here too. So we're doing Chatterfall if you're popping in at this very moment. Lauren, confident but burned out. Definitely inconsistent, frustrating. Oh, my friend. Roller coaster. I'm just scrolling back up and making sure I understand where you're at with your type 1. And it was really helpful. Thank you to those who filled out my survey form. Best now. Okay. Oh, that's my word, perimenopause. That's my definition of type 1 right now. More consistent. Frustrated with CGMs. Yes, Ken. Yes, we can make that another future call, CGMs and how we hack them. But thank you for doing that. It helps me understand where you're at. And definitely continue to use this chat here over the next hour to connect and comment. So I'm just going to move to the next slide. I'm going to shrink down this chat because it's covering up so much of my stuff. And if you're coming in late, feel free to throw a word in there that describes your T1D or just have an opportunity to scan what we have there. So we're still about 20 people on here. I'm going to go to the next slide. Um, and this slide's a bit of a joke because I just want to make sure I reiterate my desire today. It is not a webinar. It is not a lunch and learn. We are here as type 1 diabetes individuals, men and women, to connect, to have a deeper conversation and an opportunity to ask deeper questions and think differently. So I mean, I'd like to know your real food, but I don't because I want to make sure I make every minute of today count. So let's continue on. So I had mentioned I'd like this connection over the hour to go deeper on many things. And I want it to be an opportunity to ask good questions. I have two guests on here, and I actually have more friends that I actually connect with often with T1D, Ken, Heba. But I have two individuals today that I'm also going to share the microphone out of the gate with, just 5 minutes or so for them to tell a little bit of their experience and story. And I just want to reiterate a little bit of story that I have experienced in my life. And it was asking a good question. So in 2009, I was working in a public relations firm and I wasn't making very much money. And there was a conference that a friend was helping host. Her company was helping host this conference called Food is Medicine. And she's like, hey, you should join Kelly. This seems up your alley. And I was like, I really want to go. It was in Miami, Florida. but I didn't have enough money to go. So I asked that conference two good questions. First question was, can I help work it to afford it? And they said yes. So I became a worker for this conference so I could learn the materials that were presented. And it was my first exposure, I guess what you would call to functional medicine. Functional medicine, in quick definition, is getting to the root of symptoms, getting to the root of disease, getting to the root of health. So I'm at this conference called Food is Medicine. And I was the girl in the back of the room that had to cut off every presenter. And I had to hold up a sign at 15 minutes. I had to hold up a sign at 10. I had to hold up a sign at 5. And I learned so much. I learned really neat things like thiamine is totally under rated for insulin resistance. And a lot of us are B1 thiamine deficient, along with a lot of other things of how to use food as medicine. So, as an employee for this conference, there was an evening where we were all invited to dinner as employees to have dinner together and to connect. And there was two doctors there that Dr. Sheila Dean, she's also a dietitian, and Dr. Katz from Harvard. And I had the opportunity to basically ask them, listen, I've been a type 1 diabetic since my 8th birthday. I've been a dietitian for the last 2+ years. I clearly know everything, being sarcastic. And I was trying so hard. I was trying so hard with my type 1 diabetes, but I could not get my A1C better than a 7. And I asked them what I should do. And that carried on to a longer, deeper, life-changing conversation. But it came from a good question. And that conversation, that ended that story, is another topic that relates to gut health, and that can be a future call. But I want this call, I want today's topic to help you ask better questions. So that's my goal for today. I want you to be seen, heard, and feel safe. And it made me hungry. It made me hungry as a type 1 to live healthier, to live more vibrantly, and to help pave the way for others with type 1 diabetes. So I'm just going to share quickly my story on Ozempic. Again, I'm Kelly Schmidt. Some of you have not had the pleasure of meeting me. Maybe you just know me from social media. I've been type 1 since my 8th birthday, as I just mentioned. And often people are like, "Oh, you're on Ozempic," and I always often reply with, "Yes, I've been on it since before Kim Kardashian. I was on it before it was really well known. I was on it before it was nearly as trendy as it is now." And that was 2018. And I got on Ozempic after sitting at a table with a round table for Diabetes Association here in Columbus, Ohio, with other women that had type 1 diabetes. There was one that was a nurse practitioner, one that was a nurse, and another that was a dietitian. And these women sitting around the table were talking about this medication called Victoza they were on. And I was sitting there, and I often remember feeling like a teenage boy with an appetite roaring. And I was like, what is Victoza and why are you on it? And they informed me Victoza is a daily injection that's like Ozempic. Ozempic's injected hypothetically weekly. And I went and took that conversation to my endocrinologist. She told me, I can write you a prescription for this, but it's not something I want you to overtly share because it's not something I'm going to provide to all of my type 1s because there's a bigger risk of going low. So at the end of the day, the beginning of the day, even in 2018, endocrinologists are more conservative on giving them to type 1 diabetics. One, because it's an off-label medication, and two, because it has a higher risk of us going low. I'd like to expand on that conversation, but I've been on this medication for a long time. And I have learned how to manipulate the medication, and I take it in a microdose, and I take it in a funny regimen, which I'll get into later. But I've been on it for a while. And while I can't say it helped me lose a bunch of weight, I went on it to help with that teenage boy kind of appetite regulation. Um, and it has dramatically helped me keep my blood sugars sticky. It has made my type 1 diabetes, dare I say, easier, but more helpful. Um, and and I do have it covered. So I'm going to go into that even more, but I want to take this opportunity now to pause my presentation and share the microphone with Lindsay. Lindsay is my friend, diabetic dietitian as well. She is a mom. We've been connected pretty closely over the last year and a half, and also a nurse practitioner. We have Rachel Sood. I hope I'm pronouncing that correctly, Rachel, on the call. And I'd like each of them to kind of say who they are and share their experience with Ozempic and anything that they think our viewers here today would really benefit from. So yeah, I'm going to stop my share so we can all see Brady Bunch. And let's start with Lindsay. I want to start with you, Lindsay, if that's okay.
Yeah, yeah. So nice to meet you. I'm Lindsay. As Kelly said, I'm also a dietitian and I'm a certified diabetes care and education specialist. And I have had type 1 diabetes since I was 9 years old, so almost the same age as Kelly. And I started Ozempic. Gosh, I think it's been like almost 2 years now that I've been taking just a microdose of Ozempic. And my story is a little bit different than Kelly's because when I first found out about it, I actually saw some people posting about it online and I was like, well, this is interesting. And why are we not all taking this medication? And I asked my endocrinologist about it and he was like, nope, no way. Like, wouldn't even discuss it. He was just like, it's not for type 1s. And I was like, well, I don't really like that answer. So I did a little bit more research and looked into it some more and ended up finding a provider that would prescribe it for me. And I took the full smallest starting dose and I felt horrible that whole week. Like first few days, I was just like, okay, I can't do this. I was so nauseous. I like could hardly get out of bed. And I almost stopped taking it. But then a few weeks later, I decided to give it another try with half of that amount. And that was perfect for me. I felt really good. Like Kelly said, like kind of that teenage boy hunger was also something that I had experienced. And it would lead me to snack a lot at night, even though as a dietitian, I know better, but it was really hard to not eat at night. And then my blood sugars overnight would be impacted because of that. So the Ozempic really helped with all that food noise. You've probably heard that buzzword. And it just made things a lot more stable for me and a lot easier to control my blood sugars. So, fast forward, I created a whole Facebook group just for people with type 1 on GLP-1s and have been kind of just trying to pave the way and be a cheerleader because it's something that I think is really helpful for us that should be available.
Thanks, Lindsay. Right away, I want to kind of maybe ask a question and highlight an answer that many of our viewers might have mentioned in the survey that they helped fill out or even here today. And that is, I'll first say how I got coverage. I got coverage by providing my insurance two letters of as a pre-authorization, and eventually they accepted it. So I'm on Ozempic. I've been on it for 8 years. And I'll likely stay on it until it becomes an on-label medication, which that's a journey ahead, and I can share on why and how that for that. But because I'm afraid if I switch to tirzepatide is a GLP, a GIP, that I'm afraid insurance will reject it. So they accepted it, so I'm sticking with it. I'm on it. But Lindsay, I know when you got insurance coverage for your Ozempic, what was the trick there that helped you do that?
Yeah, so my provider didn't say type 1 diabetes or type 2 diabetes. He just wrote, I think it was impaired glucose tolerance or something like that, and insulin resistance, and just kind of more vague, but not like specific type of diabetes. And I think I also had to do an appeal once or twice as well. He had to put in, some additional paperwork and things like that, but it did get covered for me as well.
Awesome. Awesome. All right. I'm going to pass the microphone over to Rachel. Rachel, I'd love to hear more about you and share you with everyone. And we've
Yeah.
connected a lot over the year just through DMs and audio messages back and forth. And right away, you kind of feel like home. So thanks for joining this call today. I know you don't have a lot of time, but let's hear your snippet of you, a little bit of story that you think people would love to hear about Ozempic and GLPs, etc.
Yeah. Everybody can hear me okay, right? Yeah. Okay. Nice to meet all of you. I'm happy to do things like this and join. I am a diabetes nurse practitioner. So historically, I'm an adult health nurse practitioner, HCP with prescriptive authority. I've been in practice as an NP for 16 years and a nurse for 21 or 22 years. I can't really remember now. I'm also a certified diabetes care and education specialist. I own my own practice. It is called the Diabetes Collective. I'm actually here in my office right now, and I just see patients here in person, and then I see people virtually, and then I do audio calls for people that maybe don't need like prescriptions and stuff, but just need help and advice and all that. I'm also a full-time content creator, and I'm just kind of also a mom and a wife and a normal girl that lives right outside New Orleans, Louisiana. Probably the funny thing about me is my pancreas works at full capacity, so hopefully you don't hold that against me. I went into cardiac care, primary care, which led me into diabetes, and I started really practicing a lot of type 2 primarily, and saw a ton of people were diagnosed. started using a diabetes technology. I came in, I was raised before we started using CGM, so I never want to go back to that. And now I would say 99.999% of my population are T1D. It's just what I like. It's no offense against type 2s. I have type 2s. I just prefer T1Ds. That's my patient population. It's just what I like. I very much feel like I get maybe something out of it, out of my job, almost as much as the relationship with my patient. So it's probably like this little thing of mine. It just, I get gratification out of my job. And I feel like people with T1D overall, through the years doing this and practicing diabetology, which is a little more specialized than endocrinology. Oh, can you hear me? Okay. Yes. But I just feel like people with T1D over the years, they're just very much engaged. Most of my patients, they don't need me to micromanage them. They just need what they need. I feel like the way medicine is now, it's easier and better for me to teach people how to manage their diabetes because I can't be Polly Pocket like with them all the time. Really, it's your diabetes, not mine. Like that's how it is. So who am I to like boss people around? So that's just kind of how I take on and practice medicine, as an HCP. I would say through the years, I don't really have many T1Ds that are not on GLP-1s. There's your pancreas got attacked by your immune system. So alpha, beta, delta, zeta, and polypancreatic peptide are the islet cells, and all of them got attacked. They all produce hormones. The beta cell produces the hormone insulin, but what about all the other cells? They produce hormones too. So I've been using GLP-1s and now GLP-1 and GIP-1s in all, mostly any and everybody with diabetes, whether it's type 1 or type 2, since I can remember. I grew up in the age of when we had a medication called Byetta, and it was a twice a day injection, and everybody threw up on it. But I definitely used it. I had tons of samples in my clinic, and I would put it on people, that were T1, and I'm like, wow, they need a lot less insulin, and they feel much better, and everybody's happy. So yeah, let's do this.
Was
So
that a
that's what
meta
I've been doing.
was that a
Uh-huh.
medicine that mimicked amylin?
No, Byetta is the same as Victoza. So after Byetta, so we had Byetta twice a day. Everybody was throwing up, but their blood sugars were good, so we used it. After Byetta, we had Victoza. Literally, I handed out Victoza more than I probably drink water. So like everybody was on Victoza. Victoza is generic. It's out in the pharmacy for like $5. So there's no secret there. We, as a diabetology community, have been prescribing and using GLP-1s in the T1D community for since I was a little girl. So this is nothing new. There's lots of data now being published on it. It's definitely not off label. It's just all about, as a prescriber, when you are prescribing a GLP-1 medication, whether it's a GLP-1 single molecule or a GLP-1 GIP-1 dual molecule, it's all about the chart note. It's all about how you chart, how you set it up, and the diagnosis code on the prescription just has to match what the reason is. So for example, after Victoza, then we had more medications come out. Ozempic came out in December 2017. I'll never forget because I was big and fat and pregnant, like 10 months pregnant, like waiting for my kid to fall out of me. I was one of those, like I wanted to go natural. And I kicked that Ozempic rep like out of my office because I'm like, if one more person cold calls on me, I am going to lose my shit. Excuse my French. And then like the next month when I went back into clinic, I was like, where is that Ozempic rep? Bring her back. So, I mean, I was prescribing a ton of Ozempic then. We had it was the time of lots of samples. We still had lots of Byetta samples, Victoza samples. So I've been prescribing GLP-1s for T1Ds since I can remember. Again, not many people that have T1D in my patient population don't get GLP-1 unless for some reason there's a black box issue or it's contraindicated, just like any medicine would be, a blood pressure pill, a depression medicine, Cialis for men that maybe have erectile dysfunction. If somebody has a contraindication for any medication, number one, as a healthcare provider, you always want to keep people safe, right? So you don't prescribe medicine if it's it's contraindicated for a reason. But I wouldn't say so many people don't have it. I use it very commonly in my practice. It's almost the same as insulin. Like it's the same thing. It's just, why would you not support the other hormones when, like, why would you just prescribe the hormone insulin to help someone? So that's my mentality. After Ozempic came out, we had more stuff. Then we had, of course, the tablet version come out. A lot of T1Ds love the tablet version, honestly, because it gives them a little more control And the way I say that, I hate to use the word control because I'm a DCES and that's like a bad word for us to say, because it's just in our language. I don't ever want anybody to feel like we're controlling you or your diabetes is controlled or not controlled, because everybody knows it's so fluid, right? So the tablet is nice because the half life of taking a tablet once a day, it builds up in your system and then it kind of wears off a little bit. And some people like that flexibility of just something very light and gentle, versus like maybe an injection once a week. So I'll actually show you. I mean, why not? What are the rules? So, I mean, here's Wegovy. This came out later on. Wegovy is an auto injector. Can we see it? My camera is like not showing it. There we go. There's a Wegovy pen. So Wegovy and Ozempic are the same medication. They're both a once a week injection, and then there is a Wegovy tablet. I prescribe lots of Wegovy for T1D because its indication is not for type 2, it's for weight. So as long as somebody's body mass index is not like anorexic, you could prescribe Wegovy, um, and you just prescribe it for the reason that it is, which would be weight. We wouldn't put the diagnosis code of T1D on this. That's not what it's for. It's for weight. Same thing with, so you just put a diagnosis code on a prescription for what it's for, but that's with any prescription. I don't know why it's such an anomaly for people to like understand this. I still feel like that's all over the internet. No one understands this. And I'm like, for a birth control pill, you wouldn't put asthma on that as a diagnosis code. It's for birth control. So you just put the corresponding diagnosis code for the appropriate medication. So I use a lot of GLP-1s for T1D. The brand names that are for either weight, cardiovascular disease is, or coronary artery disease is a known diagnosis code indication. Chronic kidney disease, we now have stuff for fatty liver. We now have an sleep apnea. So we have tons of diagnosis codes. And it's just really all the way we do a chart note and set it up. There's an art to that, of course, because that's what I do all day. My endocrinologist and family doctor said I'm not eligible because I'm type 1, so they wouldn't prescribe for me. Well, you can tell your endocrinologist, I said, and I'm going to just leave that word out. I feel sorry for your endocrinologist. I
Yeah,
do.
thanks.
Yeah. So yeah, I prescribe lots of GLP-1. It helps people, I would say 30 to 40% less insulin overall. I think there's certain ones for certain people, but that goes for anybody with or without type 1. So certain ones can be for certain people. But yeah, I prescribe lots of GLP-1 all day.
Thank you.
Yeah, you're
Awesome.
welcome.
I was doing some research too, and as please continue, friends, to message questions in the chat to answer your curiosities or learn more. And hopefully, I'll just bring up topics that you're curious about or not even aware you were curious about, but I can answer. When I was doing research, only about 5% of type 1s are on GLP-1s, and I wonder how quickly that number is changing. I know just like hormone replacement therapy in women's health and perimenopause and menopause, that number is statistically changing on a daily basis of women using those hormones, and I fathom GLPs are the same. And I've seen endocrinologists as well, one, give my type 1 clients that I'm privately coaching a GLP, but also not experienced in helping them dose it. So there's so many intricacies of using these medications. One, I'm grateful I started on Victoza because that's a daily medication, and I started really low. Lindsay shared with her starting dose, it sounds like it was way too high. And on your own, Lindsay, did you figure out like I'm going to cut that in half and see where this goes? And
Yeah.
bravo to that because type 1 diabetes is about manipulation of food, exercise, insulin. And now we have this other lever of manipulating these medications, these peptides. A question in here or a few. Um, can you describe how to microdose Ozempic? Are you using insulin syringes drawing up units each week? Are you increasing that dose by 5 units each week? And how do you know when to stop? Great question. Also, does the Ozempic pen go bad after a certain number of weeks? I know it should be kept in a refrigerator when not using it. So I've been using this for 8 years, and I'll speak anecdotally. And I followed my endo's guidance. She was well informed on using Ozempic with her type 2s. And I literally started, she said, start at 10 clicks. So there's no literally dash of what that was. It was just clicks, and I was on the smallest, lowest pen. And I would go up from there week by a click. So, and Rachel, correct me, or Heba, I know you're an endocrinologist, but with children, so maybe not using this as much. Um, Ozempic's easier to microdose than Trizepatide. Because Trizepatide, I believe, isn't the smallest dose 2.5, and it's harder to go lower than that. Some people are injecting that into a sterile vial and then taking half doses and so forth. Um,
I would
we ha
tell you really quick, I want to respond to that.
Yeah,
Zepbound, the brand Zepbound, which is the molecule tirzepatide. So Zepbound and Mounjaro are the same drug. They're just branded, one's for weight loss, one's for type 2. Zepbound is now available in a quick pen, so it looks like an insulin pen. Um, so um, quick pens, as you all know, we have lots of people here dependent on insulin. You can decide how much you need or what you don't need in a quick pen. So that's very nice. That came out several months ago. So we've been really happy about that. So yeah, both semaglutide, the molecule, is available in a dial pen in the brand Ozempic, and then Zepbound is available now in a quick pen. So that is nice for people. There's always concern about people giving too much or too little, right? With a vial and a syringe. And that goes for insulin too, right? Everybody has what they like and what they're comfortable with. I mean, I think in the end, people need to do what's right for them and what they feel most comfortable with, right? I mean, I had a patient a few weeks ago, I about fell out of my chair. She'd been type 1 for 20 years, and no one had ever shown her a quick pen, like a Humalog quick pen. She had just been prescribed vials and syringes, and it just kept getting refilled, and no one had given her a pen. And I gave her a sample pen, and she's like, "Thank you so much." And I'm like, "You're welcome."
yeah.
Like,
So did you just say
easy
that
use.
excuse me, Zepbound and Tirzepatide can be microdosed like Ozempic with clicks? Or is it,
Yeah. So I think I want to do clarify. I see the word microdose as a trend word. So it depends, like when you say the word microdose, what does that mean? So
yeah,
I think what it means to you, what you're saying is, you could take, like, here's Manjaro. Trying to say, here's a pin of Manjaro. Oh, there it is. Okay. So like literally, this is 2.5 milligrams of Manjaro. This is a sample pen. But like if you wanted, I mean, it's an auto injector, so
yeah,
it would go in, right? And it's 2.5 total. But I mean, if you wanted to inject it into a syringe and pull it out and give half of it, you could. I
yeah.
mean,
Because
could do
I've
whatever you
seen
want.
that 2.5 with a lot of my clients be too much. And
Mm-hmm.
I recently this week I've had a handful of type 1 clients go on GLP-1s and they're the tirzepatide at 2.5 and they've lost 20 pounds in a month. And it's just really quick. And I'm like, well, let's talk through what you're eating. Because there's one thing to use this medication to optimize our health and weight management. But I think there's also this slippery slope. We're at risk for eating disorders, and I think there's a new era of disorders with these medications to want too much too quickly. And it's really important to optimize, of course, strength training, optimize hydration. Not only do these medications mute some hunger and food noise, but it'll mute thirst. We need to stay hydrated, support our kidneys, and also optimize protein, of course. And with all my clients, one of my top tips is protein produce. We need the color and fiber with the protein as well. But there's greatness and easing our blood sugar control and having more ease with weight loss, but to go too quickly without those other things in place can be a slippery slope. So I kind of went on a tangent there, but I have seen that when people are like, finally, I got Zepbound or Tirzepatide, and they use the 2.5, their hunger is so dramatically muted. And I do see flipping back if you can draw up. Again, this is like not textbook recommendations by any means. And I'm not here to tell people how to break the rules, but it's all about what others are doing is very insightful. It's is good to know. With my Ozempic, just like if anyone's been on multiple daily injections, again, this is a lot of my experience in 8 years that I think can be helpful to share, is I've eventually drawn up the number of clicks. Like literally, I'm writing down every Wednesday at 6 a.m. today. I take 18 clicks, but just like multiple daily injections, if I'm taking Lantus, although there's a little bit of a blip there, or Tresiba, there can be a tail, right? It's like especially Lantus. If you take that injection, you might go a little high before your next dose is due. I've noticed that my insulin sensitivity will wear off if I wait that full 7 days because I'm taking so little on a Wednesday that I take my Ozempic. Again, this is not recommended. This is what works and what's being manipulated. I take a larger dose on Wednesday and then I take an even smaller dose on Saturday. And I've seen type 1s take it every 10 days. I've seen some type 1s take it every five. And there's just different ways to tie our shoes, and there's different ways to use this medication. Um, and again, from even this conversation, even with Rachel, with her using with patients, it seems like the clicks of Ozempic is easier, but Ozempic is just a GLP. Tirzepatide is the two molecule GIP, GLP, more success in weight management with the latter as well. And last thing I want to say, and I want more questions to come in, and I'll continue to scroll, is not everyone tolerates these medications. So don't think like I am missing out. A lot of my clients as well, they don't tolerate the medication. There's other ways to optimize our blood sugar and weight management. And even I think strategies need to be in place before using the medicines too. Anyone have questions, please welcome yourself to unmute, speak up, ask those great questions. And research shows squeaky wheels get the best care. And I always mention this, and it's the more persistent you ask your endo, hey, I had a call. I understood more type 1s are using this. Can we revisit this conversation? Or even ask a good question here to get transformation, get impact, get good care. I'm going to pop over in the chat. And again, unmute. Let's chat. Let's connect. Um, Doctors said I don't qualify, but there's a trial that is starting this summer that I might be able to participate in. I've also, just one thing to say here, is I've lived around the world. I had the opportunity to live in Australia in 2010 to 2012, and along the way, I've had a lot of different endocrinologists, and it's awesome to have different exposure to different care to see everyone's a different fit. Just like there's no perfect insulin pump, I wish there were. There's no perfect insulin pump, and there's also no perfect, and I dare I compare an endocrinologist to an insulin pump. There's great things about our endos, and there's some things that might be lacking. And this conversation might be lacking with your endo, but revisit it. Have more information. There's a study from March 2026 that just came out. It was an observational study. That's what drew you guys all here today. And there was a study, it was also feeding off that in the end of 2025 that showed not only better blood sugar control, weight management, but cardiovascular and kidney health. Um, so bring this conversation to your endo, even if they told you no, because they might be continuously asked by other patients that their mind shift has been shifted. Okay, there's 15 more comments. Again, I'm going to scroll down here. Again, feel free to unmute. Um, we have our own. Yeah, and Rachel just highlighted, we have over 50 clinical trials just on T1D. And research, GLPs have been around for 15 years. People might think, oh, they just came out. They've been around for over 15 years. Insurance denied mine because along with cardiovascular, T1D was included. Now I'm using compounded. And Carol, if you don't mind sharing, when you got compounded tirzepatide, are you paying out of pocket for that, or how are you getting that?
I am paying out of pocket. But because it's such a low dose, it lasts a really long time. So the cost, is spread out over a number of weeks.
Got it. And where do you get it?
Through the medical provider with Insulin IQ.
Got it.
Yeah.
Got it. Awesome. And one thing, no question that was asked above, I didn't answer. My Ozempic, I leave most of my things in my bathroom drawer, and then every night I put them on the counter when I need to take them so I don't forget when I wake up too early for hot yoga. And I don't put it in the refrigerator in between uses. I just use it up. Similar to my insulin, but my insulin I mark every 28 days. Rachel, do you know, is there a similar life of 28 days on these peptides? Oh, you're muted. I see your mouth moving though.
Okay, yeah. So Ozempic can be kept room temperature. I say room temperature. I live in South Louisiana, so like
Yeah.
don't leave it in your car, right? It's going to break down and denature, is what we call it. Insulin does denature. And I find insulin very different than Ozempic or in the molecule Ozempic, okay? We do see people with diabetes that are needing insulin. The denaturing of different insulins are different in different people. I'll see people on a T-Slim or a tandem pump that have to change their set, like I swear every 2 days. But then others, they can let that stuff dribble out for 4 and 5 and 6 days. You know what I mean? And I know everybody does different things. We definitely have new tubing sets now that have filters on them that prevent the denaturing of insulin. So I do have some people on those 7-day sets. But Ozempic can be kept room temp for about 6 weeks. So that's what's good about that if you're traveling or anything like that. But just like you would travel and use insulin, I would just say keep it cool, keep it protected, right? The change in variation of temperature can alter it. So like if you're taking your Manjaro and you're sticking it all the way back in the fridge where it's like freezing with like, you're ruining your grapes and your salad by sticking them all the way in the back. And then you're pulling them kind of up to the front and all that. Same thing with insulin. I mean, it's kind of like, yeah. So once you use it, I usually have people just put it like back in the fridge. If you're doing an auto injector, it's just you do it and then you give it and you're done. But I tell people to just keep it cool in the fridge. I'll usually have people take it out of the fridge like 5-10 minutes before they give it, so it's not so cold. But I have a feeling most of you are pretty tough when it comes to injections. So you probably could give it through your pants. Like it doesn't really matter if it's cold or hot, like whatever. Some people are a little more like, it hurts. And I'm like, it's just a small needle. Like it's not a big deal.
Yeah.
So you can travel with it. It can be room temp. It's about 6 weeks. I mean, listen, I'm a nurse, so let me tell you something. I have got a ton of stuff in my pantry and in my laundry room fridge, and I have stuff because when emergencies happen and hurricanes come and we're out of insulin or we need stuff and maybe it has an expiration date and somebody's out of insulin, some expired insulin is better than no insulin at all. And I'm sorry, like I will never, and I will keep giving that stuff away for free because we'll know if it works, right? But if you have none, it's
Yeah.
better to use than not. So I've seen people use expired insulin and they put it in their pod and their blood sugar is good. So we know it's still working, right? And they're alive. So that's a good thing. Do I want to encourage and write down and advertise, please use expired Ozempic, please use expired insulin? No, that would not be optimal. But does some of it last past expiration date? I'll leave that up to my facial expressions.
Yeah. And Marlena, you have a comment in here. I'd love if you're open to sharing. You said you've suffered from extreme insulin resistance, being T1D for 52 years, and you started with semaglutide, moved to tirzepatide. Both worked great for a year and then less effective, and then you moved to Mounjaro, and the change is astounding. Do you mind sharing a little more about your experience, what your ability to get coverage or get those prescriptions was like, and then the differences you've seen?
Sure. So it's never been covered. And the reason primarily is because of my weight. I weigh 78 pounds.
Yeah.
So for the most part, at least they're telling me that I'm undernourished, malnourished, whatever you want to call it. But I've spent 30 years developing recipes that are safe for type 1 diabetics. My nutrition is great, so I feel great. They tell me my BMI is too low. So I got all the excuses about, no, we can't give it to you. It's not approved. Your weight is too low. So it was never prescribed. But with the insulin resistance, I was put on Similan many, many years ago, and that kind of worked. But it also became less effective after about a year. And then over time, that kind of lost the effectiveness, and I was looking for other options, metformin, Victoza, whatever. None of those were very successful. Being diabetic as long as I have, the resistance it's hard to describe. It was terrible. So when coming across something like Ozempic or tirzepatide, whatever you want to call it nowadays, I was like, well, I need to at least make the attempt and see what it does. So I got my hands on Ozempic, and I was able to test that out. And at first I was kind of shocked. The insulin resistance was reduced by, let's say, 50%. And that just continued for about a year, and then it started to become less effective. And keep in mind, I had, besides my diet being really, really good, nutrition really good, and trying to find other options to resolve this insulin resistance. And then using the semaglutide for about a year, the effectiveness started to reduce, and I was looking for another option. So that's where the whole GIP and GLP with tirzepatide became something that I decided to try as well. I just started that about I'd say about a month ago, and within the first week, it resolved any and all insulin resistance. Like I'm down to like 9 units of Thr1ve a day, and that's about it. For a short acting, once in a great while, I might have to take 1 unit, and that's Humalog, just 1 unit, and that's it. So my insulin resistance is pretty much gone. Now, from an eating perspective, it does, especially the tirzepatide, the tirzepatide does impact your desire to eat. Like like 3 times. It's double what it might be with Ozempic. So it's not that, and I spent many years training myself to fast like 16 hours a day anyway. So during the day, I was kind of used to not really eating. But when it came to that night, like eating like a healthy dinner, I just wasn't interested. And I'm like, now I understand what people were talking about because I've always my entire life had fought the food noise just like everybody else. I
Yeah.
knew what that was. So not having that conversation in my head, whether it's during the day or at night, was really astounding because the semaglutide didn't really do that. So with the tirzepatide, though, at night, that's where you really, at least for me, it was very apparent that it was doing something outside of just the insulin resistance.
Yeah.
So using that and then learning how to kind of adjust for that, I've been able to kind of play with the dosage a little bit to figure out where it is kind of perfect for me to still maintain what I do during the day and still focus on something healthy that I use for dinner at night. And then also for bedtime, because my blood sugars, especially with the Thr1ve, I'll wake up low sometimes. But what I do at night is I'm a huge fan of peanut butter. Like I just love peanut butter. And I found the perfect peanut butter that I'm kind of addicted to. So I will eat that at night and that's perfect. There's no impact to my blood sugar. I wake up perfect. There's no issues whatsoever all the way around. But as long as you find, because really it comes down to not everybody is the same. Everybody will react to these differently, and you have to find what works for you. And unfortunately, that could take a little time. You have to figure out what's going to work, what doesn't work, or how to adjust for it to make it work for you. And unfortunately, there's no easy way out of that other than to just kind of test the theory and try to find the adjustments that may be successful.
Awesome. Well, thank you for sharing that. It's unique, so I wanted to make sure I gave you some attention and to share with the group because I think it's good to share.
Sure.
I do see a chat in here. Lindsay, can you share with us after the call different types of medications and so forth? I screen grabbed your question. I will answer that in a follow-up email along with recording and any resources addressed here today. Marty, I love your question that's here next. And there was a study that came out, and this is one concern I hear from type 1s as well, and it sounds like it's on the top of your radar, and it's is the possible side effect of vision loss, the NEON study, overblown in the media, and how do you guide clients on that? Yes, exactly. My first job was in public relations, and the media can make us believe many things. But the change in using these type of medications and the influence on eyesight was when people's, gosh, I should have researched this better, but I was believe it was related to macular degeneration, and it's when blood sugars were dramatically dropping too quickly. Does that sound right, Rachel? I bet this is top of mind for you, or maybe even
What's
have
the
a.
question?
It
Yeah, I'll
was
tell you.
related to the vision and GLPs, and vision impairment. Did you see that study? It was maybe a year or two ago.
There's lots of studies on that. And actually, I do presentations on this quite frequently. So there's a black box warning on diabetic retinopathy. And this goes for type 1, type 2, doesn't matter because there is a glucose reduction potentially. And so if you've already got poor blood flow or you've got issues underlying, we can see worsening of diabetic retinopathy or that drop in glucose, like, and this kind of doesn't apply to this group likely, but for example, if I've got a type 2 with glucoses running in the 300s for like 5 years straight, which yes, that happens a lot, and they are still alive. And then all of a sudden, I like rock their world and put them on Manjaro and drop that glucose from 300 to 100. Their body is in shock because their body is like, whoa, I have been living at a level of 300 for years and years and years. And people do acclimate to that. And so when you reduce something so big so quickly and drop, which I am actually very careful to do with everyone, like very gradual and slowly, we will have some vision things. There have been some great clinical trials. There is someone on Instagram that I became friends with. She is an endocrinologist at Yale. She covers all the papers on this. And her and I and many people agree, like the risk and the benefit outweighs the risk because it is just so small. And in the population in that article that you're referencing that it was studied, it was at a hospital that they did just those patients, like at that hospital in that one city. And it's kind of like, well, why aren't you doing this and looking all over? And did you see like more of that because it was this big university hospital and like, you know, all of that? Or like, can you show us white people, Black people, men, women? Like, let's look at the whole thing. So the data was, I don't think that strong because there were some limitations there. So I think the benefit of GLP-1 use outweighs the risk of potential eye issues. I can tell you, probably I've taken care of at least 10,000 patients or more at this point in life. I can count on one hand somebody that had an eye problem.
From it. Yeah.
So yeah,
Um,
I'm
thank
not,
you. And
not worried about.
yeah, and the big takeaway when I looked at that study more closely, again, I'm now grappling with memory, but was just the dramatic change in blood sugar control overall. And Lauren, I like your question, so you sound very in the know. Lauren asked, this might be controversial as it's still on trial and not FDA approved, but I'm interested in your thoughts on retatrutide for T1Ds as GLP-3 versus GLP-1. So there's a GLP-1 Ozempic, there's GIP tirzepatide, and then now there's this retatrutide that's a three molecule, but it's working on the slower gastric emptying, but it's also working on the glucagon production. And but I'm interested in my thoughts. My thoughts is I'd be curious if someone's starting with either the tirzepatide or Ozempic first before jumping to that because it would have a profound adjustment on blood sugar control. Lindsay or Rachel, would you guys have an opinion on that?
Yeah, I've seen a lot of people come in on counterfeit retatrutide. Counterfeit compounding are very similar when I use these words. So people will get certain medications compounded, and sometimes we don't know where they come from. Sometimes they work and they're great, and sometimes the sourcing changes. So I find most of my patients have T1D. And so for people with T1D, like, life changes every day. So it's very hard. Like, your life is already so variable on how much insulin you need and don't need. So when we see other drugs coming onto the market, we want to make sure that they're stable and that that dose is what it says it is in that dose. And when you find what works for you and doesn't. So I have had a few patients come in on compounded or counterfeit retatrutide. It has not been released. It's being sold on the black market currently. It is a triple peptide receptor agonist. It is activating some of those glucagon receptors. So I am interested to see how it'll work in T1Ds. I have not prescribed it myself. I'm not able to because it's not available. I could totally purchase it and then sell it, but I'm not going to do that because we don't have that data yet. But I have seen people come in on it. I've had a few necrotizing wounds that I've had to refer to the hospital to get admitted because I think it was mixed with other things or we didn't know where it came from. There's more weight loss right now with retatrutide than Ozempic and Mounjaro. And then, not to get off track, but I'm always very, very, and this is with type 1, type 2, everybody, I'm very, focused on making sure we're maintaining muscle mass and tissue because, and it's not just, even speaking with perimenopause and men, women, as we age, it's not just what you see, it's your internal organs. So like, there's fat and muscle and tissue around your bladder, your uterus, your hips, your gum line. I've had to refer people out for $20,000 and $30,000 dental surgeries because they lost too much mass, right? So we're not just looking at the person getting on the scale and how much do they weigh. When we're looking at, does somebody need more glucose reduction or weight loss? These are important things because I don't want a woman, to lose too much weight or muscle mass and then perhaps to have an emergency bladder lift or hysterectomy and take off work for 6, 8, 12 weeks, have all this pain. I mean, that can really affect someone's life. So we do have to be careful. I am concerned about that. There is going to be some data at the ADA conference being released on this. So I'm very excited. That's in a couple weeks. So everybody should keep their eyes and ears peeled for that because I think we're going to be seeing more and more about retatrutide, but I am concerned about the safety of almost too much weight loss. And I have seen that in my practice, and I'm very careful because I don't want to hurt anybody, right? I don't want anybody to have surgery, all of these different, losing too much tissue. It's hard to get back. And I think it's hard for a lot of people to see, if you haven't had to have an emergency surgery or, all these sudden changes in your life, it's hard to see that. But once you lose that support tissue, people have back problems and things, we've got to maintain people's muscle, bone, weight. I know, Kelly, you talk a lot about that with like estrogen, progesterone, women and men getting hormone replacement, supporting bone health, muscle, tissue. So I am concerned about that with retatrutide. Is it okay for someone with osteoporosis to take? Sure. Yeah. I treat lots of osteoporosis. It doesn't affect. I mean, people are doing like DEXA scans and stuff to measure bone health, and there's a lot of data coming on. They did a lot of studies, dropped on that last year at ADA. That was like, I was in all of those sessions. There is CagriSema. Definitely be paying attention to that drug that is being studied again in combination with semaglutide. Um, what else? Yeah, there's so much on this. I'm concerned about Retaretride. I am. I'm excited, but I'm concerned because again, I treat 99% T1s. Do I have some people that are very overweight that are T1? Sure, not as many. I would say more. I have more T2s that are overweight that I would think about changing from Manjaro um,
Pituitary.
to Retaretride when it launches, which I'm thinking we're going to know something on that in a few weeks again after June 4th. So everybody just keep their eyes on the internet. Once that information drops and is published, it'll be published probably in the Lancet and New England Journal of Medicine. So that's what you'll be looking for. And that's unbiased data for everyone, just so so that would be great. Dumb question. Why would endos
I,
not prescribe? I
I
have
was
no
gonna
idea.
answer. I'm a little further up in the chat and I'll make sure we get through. We only have 7 minutes left, so I want to make sure we wrap up strong. But Eva Marie, I hope I'm saying your name correctly. Forgive me if I'm not. And she just asked me personally, did your body ever get used to your dose? Have you had to go up over the years? I want to stay low. I started 1/4 starting dose. Now I'm at half starting dose. Yes, I have. So I have gone up and it's just been a gradual observation. So it's analysis. With type 1 diabetes, I always talk about course correcting. And I have found, oh, I'm trending a little higher. So I'll go up a click. And also my clicks vary based on where I'm at in my cycle. So just as our insulin needs change, so does my Ozempic, depending on where I'm at in the month. And I'm going to scroll further down to skim some of these questions, make sure I answer as much as I can. Um, Carol shared, I notice I have more low blood sugars the 2 days after injection. Yep. Then things stabilize. I think that's great to know. Just like there's a tail, right? I take my larger dose personally. On Wednesday, I take a few clicks on Saturday overall. Again, feel free to not unmute yourself, friends, if you want to make sure I get to your question. I'm observing this quickly.
I'm just going to throw out the half-life of the injectables. The half-life of the once a week is technically on paper 5 days, but I have seen everything all over the books, everything. So again, back to individuality, what works for you is what works for you. And like nobody should be arguing with you about your body. I mean, we can download a pump report and see it. So if somebody doesn't believe you, that's crazy. So I see the half-life of 5 days enables us to prescribe it for once a week. But sure, different doses can wear off sooner and later. And to Kelly's point, certain times for women, what menstruating, going through menopause, certain things like that, certain doses just work better than others. So the tablet wears off quicker though. So
Rachel asked, I know type 1s lack amylin. So there's a medication called Simlin. I think Marlena mentioned she was on it at a moment. It's more complicated to routinely take this Simlin medication and it's still available, but you have to take it like 15 minutes before your meals that have at least 30 grams of carbohydrates and at least 250 calories. And if you think about taking insulin, you think about your pre-bolus and you think about these other things to continuously layer on, let alone eat, it can be not as easy to use. And these GLPs have taken more dominance and success in those medications. Um, let's see, there's a few things I made note. I want to make sure I wrap up. Thank you everyone again for being here. I will review the chat further. I will follow up with a recording, but this is just the beginning of a deeper conversation that I wanted to bring type 1s together who are already very curious and hungry for better information. I appreciate my endocrinologists. I tell my clients if they don't have an endo to ensure they have one because we need great doctors in our village to help us take care. But on the other side of the coin, I think there's a lot more to explore. One of the questions, I asked you, what's one word that describes your type 1 diabetes care? And then I asked, what's your favorite food? But I don't want to take too much time away on knowing what your favorite foods are. But each year I'm going to go ahead and mute people. I'm getting some background. I think I can. Let's see here if I can. Oh, shoot. I'm so used to so many. There we go. Mute. Um, I got distracted there, but I was going to say, I like to ask clients, even myself, what's your word of the year? So we're coming up on the sixth month of 2026. Can you believe we're halfway through? And my word of the year this year is grace. And grace has so many meanings, but also in my work and my practice, I use something as a framework, and it's called the grace method. So in type 1 diabetes, I think there's a ton of room to continue to talk about. And GRACE is an acronym for gut health, routines, adrenal health, clean living, or liver and exercise. And I think that side of the coin of type 1 diabetes has so much room to explore, to connect, to learn, to improve. And when we have insulin resistance, it's not carbs' fault. It's not carbohydrates' fault. It might be nutrient deficiencies. It might be the gut health. It might be so many things. And my goal is to welcome anyone interested. My goal is to open up an opportunity to have more conversations like this. My idea of what my intuition, what I feel like my soul is leading me to offer is a Thrive collective. I'm just going to take 1 minute to talk about this. I'm not here to give a sales pitch. I'm here to create change and live my purpose. And on February 5th, 2002, my dad got a pancreas transplant. And in that waiting room, I said, I want to change the world one day at a time. And I do that in my work, but I want to reach people better and create more of a community. And I'd like to host a Thrive collective. So what that is entailing is I want to co-create. Just like you guys answered my survey form for today's call, I want to know what's going on with you on a topic and how I can provide information to help you improve. And each month might differ on topics, but I think there's more room to talk about GLPs. But we'll talk every other week. Talk every other week, come together, have conversations. I will still source input from you. Potentially, I'll have friends on here to help cover a topic, or maybe it's just to regroup on this topic specifically. So after today's meeting here, I will send a follow-up with the recording, answering one of the questions I screenshotted here, and also just an invitation to invite you in there. I want this Thrive Collective to stay small. You know, I used to think my biggest goal is to be the best and biggest dietitian for type 1 diabetes, but I only care about being the best to help change lives. And I don't want to be big. I want to have intimate conversations with people who are hungry for more. So that's what the gist is of the Thrive Collective. And it's evolving. Again, I want to co-create it. What do you need? What can I supply? What can I help you transform? Last few things I want to bring up here is we talked a lot about GLPs, GIPs. We said a lot of funny words. Hopefully they were familiar to you. Coverage can vary. Keep asking your endo for help for that pre-authorization and find other ways around it. There's another individual in our village that can help us, especially for women, is that's the gynecologist and perimenopause. Last year, I used to consult for a women's health, functional medicine practice, and GLPs are now being utilized as a medication in perimenopause and menopause. So gynecologists are becoming more informed to have educated conversations with them to help. And again, the dosing can be manipulated. If the medication you tried it didn't work for you, maybe it was too high. Maybe you started at that 2.5 that some of my clients tell me that made them so sick, and so forth. Last but not least, I want to help simplify complexity. And I'll leave you with if you're feeling completely frustrated and defeated, there is, dare I say the word natural, but it is natural. There's marketing create like crazy to have consumers buy things, but there's a product called Curb, and that's a hops extract from New Zealand that behaves like a GLP-1. The New Zealand government in 2020 put billions of dollars to fight obesity, and they came up with this product. And that is something that can be sourced directly from Curb, or I can give you a source to full script to get it with a discount. But I highly encourage you bring your village in, you bring your doctors in, ask them their input on this supplement for you to explore how to break some insulin resistance, help with food noise, and so forth. Um, and I'm going to take a breath and I will say, please unmute yourself for those who are here. Thank you for every minute you've given us today. What can we end with to make sure I don't leave anyone on the edge of their seat wanting to know an answer to something? Anyone have a question dying to know? And I'm going to look at the chat, although there's 15 I'm behind on. Um, Thanks for being here. Let's see here. Anyone have any last minute? I'm going to go right to the bottom. Thank you so much.
Kelly, I'll unmute myself. I know I talk too much, but I tried to put as many links for all of you. I think it's really important that us as healthcare providers use credible links and information for you to see unbiased information. Yes, you learn all from each other, but this is definitely not made up. Kelly's story, my story. I mean, I've had people with T1D on GLP-1s for many years, so that's why I'm pretty passionate about it. And that's why when things like this get published and they get on paper, we know like that's a monumental moment. I mean, I cried in the room when the first GLP-1 study was published. That was huge. I mean, I cried coming out of it because I knew this is going to push the needle so that people can get what they need. It was really exciting. That's why I've shared all of this with you. That's one of the clinical trialists, Dr. Shah. He does a lot of work on GLP-1s in the T1D space. And I interviewed him right when we came out the room. I think we were both crying. So this is just an exciting time, I think, for everyone. Yeah, I think everybody has to be responsible. And yes, different things are used, different doses in different people, right? But overall, it's just an exciting time in diabetes to have all of this available for all of you. And I hope you can get what you need from your provider. And that's why I want to give you all of that data, because it's not made up. It
Yeah.
works, I promise. So I want you to have that power.
Thank you. Thank you. There was a question there I want to answer. I think, Cynthia, you're still on. I have had some very scary lows on Ozempic. It's just learning it's relearning your type 1 diabetes when I started using this medicine, um, and what I need to do to treat those lows. Again, I should get paid for Elevate. That's a powder I use for treating my lows, and they work instantly. And it almost feels like insurance to make sure I can keep my blood sugar at target without fear. But I just had to learn to dance with lows a little differently. And the first few times I went low on Ozempic, I overtreated. But we learn, we pivot, we course correct, as always. Great question. If you guys have follow-up questions, reply to my email. And again, I want to thank Lindsay as well for joining here. You guys will likely see her around. Lindsay might be of help if she's going to be like a substitute teacher if there's any meetings that I can't make. And that's to be explored month by month as needed, and so forth. But more information on the Thrive Collective, if you feel emotionally drawn to keep connecting, I hope you join because I want to help people just like you. And what a great topic for us to kick off with. So thank you, everybody. Yeah, I don't think there's any last things, but take care. I appreciate you all. And thank you,
Thank you for
Rachel.
organizing this. It was wonderful.
Yay.
Thank you, Kelly.
Yay. Good.
Thanks for inviting me, Kelly. It was nice to meet all of you.
Yeah. My
Have a great
Instagram
day.
friend.
All right. Bye, everyone.
I love it, Ken. Bye, everyone.